Turn my microphone on. Oh, hi, David. Sorry. I was just wondering who we didn't have. So good to see you. Oh, feedback. What was that? Are we okay now? No?
So we're hearing you twice, which is one.
That's right, they're hearing you twice.
Are we blaming Barbara? Okay. Apologies for the delay. We're just sorting out the microphones. That sounds all right. Is that okay? It's still echoing. Okay. Is that okay?
Yes.
Everybody happy with that? Okay. Apologies for not hanging on a few minutes for you, David. Okay. Thank you. Thank you for coming in. Anyway, okay. Good afternoon and welcome everybody to West Berkshire Health and Adult Social Care Scrutiny Committee. I'm Councillor Martha Vickers, Chairman of the committee. Members of the committee present this afternoon are Councillors Dennis Bennyworth, Councillor Nick Carter, who should be joining us online. I don't think that he's there yet. He is there, is he? Owen Jeffrey in the room, Paul Cander, Alan McCrow, David Marsh, and Stephanie Stevenson, all councillors. And also, we were expecting Councillor Nigel Foot to be present. He did say he would be attending, so maybe he'll be joining us as soon as he can. He is Chair of the Health and Wellbeing Board, so let's hope he'll be joining us soon. Council officers and external partners joining us to advise and support the meeting are Stephen Bow, Public Health Consultant Paul Coe, Executive Director, Adult Social Care and Public Health, and Barbara Billett, Quality Assurance Manager, Adult Social Care. From Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board, we will be having Helen Clark, Associate Director of Place, Hugh O'Keefe, Head of Pharmacy, Optometry and Dentistry, Daphne Barnett, Interim Associate Director, Complex and All Age Continuing Healthcare, Diane Uckley, Clinical Service Lead for Berkshire West, Leila Johansson, Head of All Age Learning Disability, All Age Neurodivergence and SEND, 0 to 25, and Nikki Cartwright, Director of Performance and Delivery, All Age Mental Health Community Services, All Age Learning Disability and All Age Neurodivergence and SEND. Gosh, that's a mouthful. Vicky Phoenix, on my left here, is the clerk for the meeting, and Gordon Oliver is the Zoom host. And this afternoon's meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. If we hear the fire alarm, we must leave the building immediately via the emergency exits. The assembly point is the Dolphin Car Park, and if the lockdown alarm sounds, we will await instructions from officers. We will adjourn the meeting until such time as it is safe to proceed. Do members have any questions about the way in which the meeting will be conducted before we proceed? No? I don't think so. Right, item 1, apologies. Vicky, do we have any apologies?
Yes, Chair. We've received apologies from Councillor Joe Stewart and from Fiona Warby, Lead Officer at Healthwatch West Berkshire.
Thank you. I'm pleased to say Councillor Nigel Foot, Chair of Health and Wellbeing Board, is just walked in the room. He's just about to sit down. So welcome, Nigel. Thank you for coming when you're so busy. There's a place here or there, wherever you want to sit. Do you want to sit over here next to Barbara? Thank you. So item 2, the minutes. Can I have a proposal to confirm that the minutes of the Health Scrutiny meeting held on the 30th of September can be approved as a true and correct record of the meeting? Thank you, Councillor.
I propose.
Thank you, Councillor Jeffrey. And a seconder? Thank you, Councillor Stevenson. All in favour? Thank you very much. I'll just sign those. Again, thank you very much. Right, actions from the previous meeting. And we've got an action tracker. You'll see in your papers, starting on page 11, very comprehensive action tracker of all the things that we're basically tracking to make sure that the recommendations and that are from previous meetings are being progressed. Has anybody got any questions about the action tracker or any comments? No? Okay. Oh, Councillor Kanda?
Yeah, I think I made the point yesterday with regards to tracking dates and target dates. And maybe if a target date has slipped and it's still in progress, maybe we need a new target date as a suggestion or something.
You've got any comment about that?
No, I'll have a look at the action track and get back to you, Paul, if I've got any questions. Thank you.
Thank you very much for that. Councillor Stevenson?
Yes, thank you, Chair. I know that you are following up the task group report that we prepared for children's mental health, but I think I did want to ask just why it had taken quite so long to get to executive. Is that being followed up?
Yeah, it is being followed up.
Thank you.
Sorry, haven't turned myself back on again. We were hoping that it would have gone to the executive this week. Would have been too late for this meeting, but we have been told that it's not going to the executive this week. Probably we will go to the executive in February, and we are progressing what the issues are there, because those of you who were on the task group will remember that we actually were quite concerned that our recommendations, which we thought were very important at the time we finished the task group, were progressed quite quickly, and we had an extra meeting, an extra special meeting to make sure that it happened as quickly as possible. So we're disappointed that it's taken this long. So we are looking into what the issues are, and it will definitely be coming to the March Health and Adult Social Care Scrutiny. And we'll have a little bit, if we have some more information between now and then, we will share it with you. But there are obviously some issues that there is some concern about. So we'll be progressing that, but we think it's an important piece of work, and we'll keep you updated. There's also a comment that we've received an update on the recommendations made by the Healthcare and New Developments Task Group. That's another important task group that some members of this committee were on, including our new Chair of Health and Wellbeing, Councillor Foote, was on that one. This is also an important task group, and this is being monitored outside the committee. There's no specific comments, but according to Vicky, that actions are being taken, and so far we're happy with the progress. So if there was some concern about the progress, we would bring something back to this committee, but so far things are progressing well there. Any other comments about the action tracker? Okay. Right, thank you very much. It is quite comprehensive, but we do take on board the comments that have been made. So next we have item 4, declarations of interest. Any declarations of interest relating to items on the agenda? No. Item 5, petitions. Any petition?
No petitions have been received, Chairman.
Thank you. Thank you, Vicky. So item 6, our first report, is an update on oral health and dentistry. This was a key item at the Health Scrutiny Committee in March, earlier this year. And because it's something that members are really quite concerned about, we asked for an update to be provided on further developments. So we have here today, we have Hugh O'Keefe. We got Hugh O'Keefe, is he there? There he is, he's waving. Head of Pharmacy, Optometry and
Dental.
And also both. So shall we ask Hugh first for his report and then Stephen? If there are any issues following Hugh's report, you can ask the questions then, or you can wait until Stephen's given his report. These are updates. So we're just asking Hugh and Stephen to give us the highlights of things that have changed or no comments to the first report. Thank you very much. So over to you, Hugh, for your comments.
Thank you. Can I just, can you hear me okay? Can I just check in? Oh, I've lost, yeah. Can you?
I can hear you, but I'm on remote as well.
Okay, thank you.
Hear you okay at the moment. We'll let you know.
Yeah, just thought I'd just check in to make sure that I'm not sort of
That's fine.
as you're muted and you don't know it, do you? Yes, so thank you, Chair. This is an update report, the one we sent in March, and thanks for inviting us back about dental services. So just some highlights, really. So the paper talks about the changes being made to the dental contract nationally since 2022. This is to deal with a lot of the challenges that patients faced around access and for the dental profession themselves. And you may have seen there's been some news today about further changes coming in the contract from April. So we're just finding out a bit more today about the details of that and whether that's going to be sort of fully planned to go live from 1st of April or will be phased in over the year. And there's been some outlining of what those changes will be, which will include a sort of greater emphasis on oral health promotion and prevention, children's oral health in terms of some of the treatments they'll receive, and then building in the urgent dental access to those core contracts. So these are going to be the biggest changes since the contract was introduced in 2006, the one that we have now. So we're just hearing a bit about that today. Then just in terms of the local actions, we've in the paper updated in terms of what's going on with urgent dental care at the moment, what we've been doing to replace activity lost due to contract handbacks. So 2 new practices, for instance, have opened in Oxfordshire in the last couple of months. The flexible commissioning scheme that we're running for vulnerable patients to try and help them access NHS dentistry. And then children's oral health improvement pilot that we're just about starting as well. So there's some of the key areas that we've focused on. Just in terms of where we are with things, access to NHS dentistry is continuing to improve in terms of those numbers of patients coming into the system, but we're still some way below the pre-pandemic levels in terms of those levels of access. Contract delivery amongst the practices is increasing. It is going up year on year. And in 24/5, that was particularly boosted by the new patient premium that was paid during that year to dentists. So West Berkshire, the practices delivered 85% of their contracted activity last year, boosted to 90% by the new patient premium. In common with some of the more rural areas, I think there are challenges around recruitment in West Berkshire. And this year we've focused our Golden Hello scheme, which is designed to fund dentists coming to work in harder to recruit areas. So we have focused that on our rural areas this year, so which is really the sort of outskirts of our patch. And we've got 16 practices that have now said they would be interested in the receipt of that funding. I think one of those is in West Berkshire. So West Berkshire is one of the areas that we have approached about the Golden Hello scheme. Urgent access has been a national priority this year. That links to the government manifesto commitment about 700,000 additional appointments. And we implemented this scheme in April. And there's been, since then, a national scheme has been launched in September. And we've got 5 practices in West Berkshire, taking part in that scheme, so, providing those additional appointments. Overall, we have seen a growth in the number of urgent appointments being attended by patients, but we're still some way to go in terms of hitting that target that we've been set. Children's oral health improvement is a sort of part of a wider prevention focus for us in terms of there's quite a strong correlation between IMD area of residents and extractions in hospital. So we're looking to run some pilot work with practices taking a more sort of proactive role in trying to get children into the dentist at an early age. so that they are used to going to the dentist. It's not the first time they attend is when they have a problem. That involves working closely with other agencies, such as the local authorities, linking to the supervised toothbrushing scheme. And we've got 16 practices taking part in this pilot, which is just getting underway as we speak. And that's running till March 27. Just also to mention, we're also taking part in the national pilot for blood pressure monitoring in dental practices. We're one of 11 ICBs doing that as part of CVD prevention. There's 12 practices involved in that. One of those is in West Berkshire. We're due to get a national write-up on that quite shortly in terms of how that's gone and where we go from here. That's also involving optometrists. So trying to find other settings in primary care to provide that sort of support and care for patients. The other thing we've got in the paper is details of what's happening with the commissioning of the specialist services, specialist dental services, in terms of those referral services, the challenges they're facing, particularly around waiting times, and then what we're doing to try to address that. So that's the update report from the ICB.
Thank you. That all sounds very encouraging. A lot of things happening. Obviously, there's a lot of disturbing data out there about the nation's dental health. I mean, we're aware of, I think there was something on national radio the other day about 43% of adults in the country are suffering tooth decay, which is the same as 25 years ago. So there's still, obviously, there's an awful lot of work to be done. And we do ask the question here, you know, in West Berkshire, we're a relatively affluent area, and yet we still have these problems, really. So there's a lot of work to be done, and we're suffering, having issues. What's going on in the rest of the country, you know?
Yeah.
This work is really quite urgent. You've mentioned pilots, a pilot for tooth brushing and for various care. After the pilots, is the aim to sort of broaden the scope of these projects? Because a pilot is meant to identify what needs to be done, and then one hopes that, you know, after that, you know, there'll be further rollout. It's difficult to say whether that will be the case.
It's certainly a case that is multifactorial in terms of oral health. So yes, the dentists will often be seeing, you know, when the problems occur. We do want to try and see if we can get a bit more in front of that in terms of dental practices working with other agencies to, particularly for children when they're young. We were running a thing called a Starting Well project pre-pandemic. So I think it's sort of a good sign that we're beginning to get these sorts of things going again. There's a bit less of a sense of, you know, having to just try to recover the access situation. That's still ongoing work, but we're in a much better place than we were in a couple of years ago on that. So I think that is giving us more opportunity now to think about what we do around prevention. And as I said, we are waiting for more details about the changes coming to the national contract. That has got a bigger focus on prevention, and it is trying to incentivize through the payments made to the dentist that they play a stronger role in that. That has felt to be one of the missing bits, really, of the 06 contract.
Thank you for that. Shall we have Stephen's report and then members? Oh, Councillor Jeffrey has.
I think this is the appropriate time to raise it, but if I go to page 2 of 6 of the report, page 20 of our pack, the penultimate paragraph says the rate of tooth extractions in West Berkshire was 376.5 per 100,000, similar to the England rate of 368.0. But statistically higher than the southeast average of 239.2. If West Berkshire is okay with the typical rate for England, fine. But if we are running 1/3 higher than the average rate within the southeast, I'd have thought that was a question I would like, and maybe it's not one you can answer here and now, but if we could have an answer to that, because that is a massive differential.
Do you want me to come back on that? Should I try that now?
Yes, please.
Not
Yes.
just because Stephen's, I think that's out of Stephen's report. So Stephen, I don't want to cut across.
Okay, well, maybe we'll let Stephen give his report and then maybe he can answer that question.
Councillor, could I just ask my question of the speaker that's just gone? I was just
If it's to
waiting
do
to
with
ask.
this report? Yes,
Yeah,
certainly.
it is. Yeah,
Councillor
yeah, yeah.
Marshall,
Yeah, hope you can hear me. Thank you very much for the report. That's great. On the Golden Hello, does it have any link with where you have private practices? Does it aim at trying to encourage them to take on NHS patients, or is it specifically for people starting up new practices? I know you mentioned rural areas. I just wondered, for example, in my patch, we have a private practice that doesn't take any NHS patients. Does that Golden Hello go anywhere to aim to try to ask a current practice to take on NHS patients, if that makes sense? Thank you.
It is a bit of both. So the Golden Hello is essentially aimed at current practices to support their recruitment. And then we have got some new practices opening, and we will support them as well in terms of their recruitment. I think one of the issues about recruitment into those areas is, one, I think there's a difficulty, full stop, just getting dentists to work in some of those more rural areas. And then there's the other issue about trying to get them to work on the NHS. So in some of the practices, even if they're NHS, because all practices really, in terms of all the NHS ones, are all a mix of NHS and private. And so it's trying to get an increased commitment to the NHS in those areas.
Thank you very much.
Thank you, Councillor Carter. Councillor Stevenson?
Thank you, Chair. I've got a couple of points, if I could ask Hugh, please. First of all, I want to say that I was naively shocked to read about the Urgent Dental Care Incentive Scheme, because I couldn't imagine any dentist would actually refuse to see someone in pain. And I read that presently practices are only required to see patients in a current course of treatment. So that's what I was very surprised about.
Yeah.
I really hope that this does solve that problem.
Yes, I mean, I think that's right. I think it's not widely understood. Patients aren't registered with a dental practice. So there's a sort of benefit, you can go wherever you want. But then there is that issue about the ongoing care. And so, I mean, it is worth saying that the urgent dental care is something that is widely provided in practices. They're looking to increase the level of provision that we have, but it's up from sort of nearly 100,000 appointments a year to 110,000. So most urgent dental care is done in dental practices. Not I think there's people go to hospital or things like that, but actually the number of people who go to A&E each week with a dental problem is half a dozen in Bob, compared to the numbers that are going to, and some of those may have medical issues. So if they're directed in by 111, it might be it's appropriate that patients then are sent to A&E. One of the things that we're waiting to just understand more detail, this is the devil in the detail, but these contract changes, is the idea that dentists will be contractually required to see urgent patients. So we're just, that's the spirit of what they're trying to introduce now. So in that respect, that is quite a big change. So we'll again have to understand how that plays out. So that would mean everybody then setting aside some capacity to see patients urgently, and then we would put resource into those contracts, sort of based along the investment we put into the scheme we're running this year. And that would go in as a core allocation to those contracts.
Okay, thank you very much. And the second thing I wanted to ask you, I think it's really good to see blood pressure monitoring carried out in dentists' practices. But I think you said there's only one in West Berkshire. Is there any chance we could make this more available?
I think so. I mean, so we, as I said, we're part of the pilot, so we've gone through a sort of quite a rigorous process to set the practices up, because this is something a bit different to what they normally do. Practices sign up to it. So it is being tested to see if it works, and the practice that's coming from Newbury has gone great guns. They've really delivered a lot. We actually had to sort of advertise the scheme with practices in about June, because we found there was a bit of a dropout rate. So practices might sign up to it, but there's a view that might be held by some staff that they're dentists, they're there to treat patients' oral health, they're not there to check their blood pressure. So it's not, so some are really keen and some are less keen. And then we find even when they sign up, that could be an issue. So it's an opt-in situation. So if the scheme's continued, I think it would be, it would still work along those lines. I think the practices, see that it's something for them. We had an interesting example of someone who trained in America, and he said all patients there have blood pressure checks before they go to the dentist. It's built into the American system. It's not built into our system. So I suppose it'll take time to develop. And then it's also, this is part of the wider primary care work in terms of neighbourhoods, trying to get getting primary care teams to work together. This is a good case where if issues are picked up, the patients are then referred to the pharmacy, who can carry out further checks or do the ambulatory for the 24-hour checks, or they can refer into the GP stuff. So it is trying to join bits of primary care together. So I think there's a sense here this has got some real value. There is just an issue which is part of the arrangement we have, is that these checks are done at the point that patients are coming in for a checkup, not if they're coming in for treatment. They will have raised blood pressure if they're coming in for treatment. So it's being careful about when those checks are done.
Thank you very much.
Thank you.
That's interesting. Councillor Kanda.
Hello, thank you. Just a couple of questions. You talked about the increase in the UDA's performance up to 90%, I think it was.
Yes.
Based on the fact that we had increased the benefit to the dentist. Do we know what actions they took? Did they basically open longer, or did they churn them out quicker, or did they just take on more than they would have turned some away?
I think it's probably.
So
Sorry.
Money was the incentive. So what was the change in behaviour?
It's a good question, and I don't think we absolutely know the answer for that. But essentially, it's probably that their patients are getting more dentally stable. So there was an issue post-pandemic where dentists were shut for about 3 months during the pandemic, and then worked on the basis of a reduced service for about 2 years. So as they opened back up and patients came in, there was significant deterioration in their oral health. That meant more chair time to provide the treatments. Those patients have now come through the system in terms of their recalls. So there's probably some stabilisation going on. So that means the dentists can get through their patients more quickly in terms of their care.
But that would imply that the additional benefit they got paid actually didn't make any difference.
For the new patients was trying to encourage them to create space to get new patients into the surgery. Mainly, dentists will work on the basis of a list of patients who attend regularly who they recall. Okay.
And then just one last thing related to that. In the table, we seem to be the 4th worst performing for percentage delivery before the MPP, and even after the MPP, we're still not the best anywhere near. Do we know?
Yes, and sorry, I was just looking at it, and I think we'll see that link with rurality.
With what? Sorry.
With rurality.
Oh, okay.
It tends to be those areas that are not performing as well.
Okay, yeah. I guess that kind of makes sense. Vale of Whitehorse, for instance, is low. Okay, thank you.
Yeah.
Thank you, members, for those questions. Councillor Foote, do you want to ask a question now? Do you want to wait till Stephen's done the report? You go ahead. Yes, I know you've got experience in the past.
Well, thanks, Chair. Yes, I should declare a slight interest because I was a dentist for 40 odd years. I mean, latterly I was a specialist, so I wasn't in general practice. But just for context for the members of the committee, it's interesting to hear about the problems in rural areas because I think it's important everybody realises that dental practices are businesses. So they have to make a profit. Otherwise, they go under and they can't afford to keep going. The overheads for running a dental practice are pretty high because the equipment is expensive. And also, quite rightly, your assistants are trained up. So there's a pay grade. Just for historical context, years ago, you could, as a dentist, train up people straight out of school, and you could more or less pay them what you liked. And at that very junior level, it wasn't a great deal. But now, quite rightly, there are qualifications and people are paid at a grade. So I think there is a major challenge here that in our area, for NHS treatment in rural areas, it's a big challenge. This is a problem that is nationwide. It's not limited to West Berkshire, but we have a problem in West Berkshire because we are a rural area, apart from Newbury and Thatcham and the big conurbations. So just for context, really, Chair. Thanks.
That's very useful, Councillor Foote. And we did, in fact, I think at our meeting in June, we had a dentist who raised similar issues about the overheads and about did people appreciate, the costs, that it wasn't just the dentists were money grabbing and et cetera, that the overhead. So thank you for expanding on that. That's very useful. I think we'll move on to Stephen's report because I'm watching the clock here and this is an important issue, but we do need to hear from Stephen and see what other questions we've got. Thank you.
Thank you, Chair. And also thanks to Officers Neris, Probert and Alice Luca for their input into this report. So the paper that I'm talking to looks at the public health activity, which aims to complement the ICB dental services and where the local authority is supporting preventative measures. So I won't go through all of it. So as Hugh mentioned, the government's making changes to the dentistry contract. And I think Hugh's covered the dental access data that is in the report. Councillor Jeffrey, you had a question about the data on tooth extractions. We've been in discussions with the ICB and NHS England colleagues to understand. And we've been advised by the NHS England public health consultant lead that there are concerns actually with the data quality and variations in how it's collected in different areas, which might go some way to explaining the differences, and that this should be resolved as part of a new national process for data collection of dental procedures, which started in August. So hopefully more accurate data should be available online in future. But I do think it's a good example where we've been relying on sort of published national data. And we do need to build our local collective data and intelligence infrastructure so that we can answer these types of questions, more effectively locally. Shall I pause? I saw your hand go.
You want to come back on that, Councillor?
If I may, just literally, I can understand what you're saying, and that gives me a good deal of relief because I just couldn't believe that such a differential could be in there. Can you give some kind of time scale on how long you think it will take to get this resolved so that we know we're on firm data?
I'll probably have to come back on that one with a precise date. Yeah.
Thank you, Stephen. Councillor McCrow.
Thank you. So I had a question on the statistics, and I suspect the answer might be similar. It was the next paragraph, actually, where it said the percentage of tooth extractions with a primary diagnosis of tooth decay amongst 0 to 19-year-olds was 17.2% in West Berkshire, which is lower than the southeast, which is 40%, and 62.3% nationally. 17.2% seems exceptionally low, because I would have thought the majority of people had a tooth out suffering from tooth decay personally. I can imagine there are other reasons. Perhaps could you shed a little light on that, please?
Absolutely, and that really stood out to us as well, so that's why we wanted to look into it. I think it's the same data set, so potentially the same caveats apply. I mean, I could speculate about it being to do with more orthodontic treatment or non-decay related extractions, but I haven't. I'm not sure if NHS colleagues are able to verify that, or if we need to await the data sets.
Councillor Foot has put his hand up. Is that? Sorry?
Sorry, Chair, it was just to say what Steve said
Okay.
just now, that it could be orthodontic extractions, of course.
I must say, I thought that was a bit odd, and then realised that that was probably what it was. But it was would have been quite nice if that was mentioned in the report for us that aren't particularly, up on these matters. Regarding the data, I had a question on the. I think it's the figure 21, page 21. I think it's figure 22, and I don't know whether you've got access now to the figures on the last report in June, but in June, the difference is, in particular, the I think it's the 10 to 14 looks as though it's almost doubled from 2022-23 to 24-25. So it's just an odd thing to see. Is that to do with inaccuracy, or is there a reason for that, or are people catching up on their orthodontic stuff, or do you have any idea?
So one thing to note is the error bars are quite large, so that you'd expect quite a lot of fluctuation, but nevertheless, big changes would be surprising. I think when discussing this with Hugh, he did mention the I don't know what the right phrase is, but the timeline of trends related to kind of recovery from COVID might have something to do with it. But I don't know if you might want to clarify that point if you can.
But you want to comment? Yes.
Well, there was certainly a significant pickup in activity between 22-3 and subsequent years. So 22-3, we were coming out of the pandemic, so there will be more activity going through the system. Also, I think in secondary care terms, this data really only looks at what happens in hospitals, and this is Stephen's point about the data. Most extractions on children are done by the community dental services, but those stats are not readily available. So this is picking quite a small proportion of children in that respect. And our area, Royal Berks, in terms of its recovery, in terms of numbers of long waiters for oral surgery, has recovered more quickly than other hospitals. So it might be their throughput was greater than some of the other hospitals have managed to achieve. But it is speculating a bit. We're not entirely sure. But anything that's around that period just after the pandemic, it does start to create some statistical oddities.
Thank you very much. Have you got more to say, Stephen? Or?
Just briefly to highlight the update on the supervised toothbrushing programme. So the contract's now signed and the service is now being mobilised across 15 settings, which covers 21 classes of 30 children in West Berkshire. Also on the oral health survey, which was mentioned in the last report as to be conducted, it's now been conducted. 5 care homes were visited, total of 35 questionnaires and examinations completed. The data's still being analysed, so we can report that back in due course as to what the findings were. Just to sort of conclude on the future work on oral health in West Berkshire, so the best start in life, as many of you will know, has been identified as a priority for the Health and Wellbeing Board. So it's likely that there'll be oral health for children will be picked up as part of that. And we'll continue to work with colleagues in children's services around the Family Hub redesign. in response to the government reforms and work closely to ensure that oral health improvement objectives and services are fully integrated into that design.
Thank you, Stephen. That's all, you know, it's good to hear all of that. I think we will have to move on, but I think it's important to point out, I mean, you refer to it now on page 23 in next steps, 5.1, you do refer to the oral health. You know? Is that somebody got their microphone on, or maybe they've turned it off? Okay. So, we did ask this committee, which is really concerned about oral health, for an oral health needs assessment. And we do appreciate the resources that would be needed for that. You do refer in that last paragraph about work possibly being done linking to best start in life, but it is important that we know what's happened to that request, because it's a recommendation from this committee, so really it should be addressed and we should know what the response is to that and whether that will be taken to executive. So can you, if you need to, possibly take that away and give us an answer to that?
Yeah, very happy to make sure there's a response to that.
Thank you very much. Well, thank you everybody for your reports, and thank you members for your really good questions. And I think obviously we'll be keeping track of this issue, which is important, but we'll give it time to actually see how these new initiatives span out before we look to bringing it back to this committee. So we'll give it some time. So thank you very much. That was an interesting discussion. Right, we're moving on now to item 7, all age continuing and complex care. And we've got Daphne Barnett and Diane Utley, who will be providing an overview of their report and highlighting key changes since their attendance at the Health Scrutiny Committee in June of this year. So can we hear from them now? Hello.
Hi. Hello. Good afternoon, panel. Daphne Barnett, as you know, I've attended on the last 2 or 3 occasions, and we have Di Utley who's going to present today for Berkshire West.
Thanks, Daph.
Thank you.
Hello. Thank you, Chair. And hi, everyone. Just take a minute because I wasn't here in June. So as Daph said, I'm Diane Utley. I'm the clinical service lead for Berkshire West Place. I took up post in December 2024 and officially started on the 1st of January. As you know, I've been invited here today to update you on the activity that's taken place since the last update in June. And I hope you've all had the time to have a look at the slides we had shared ahead of this meeting. We did note that there was a further request for local authority conversion rates. And if these haven't been shared, we will share those with you so that they can be shared with the members. So over the last 12 months, I've been working closely and collaboratively with our 3 local authority partners and other healthcare colleagues across the local landscape. I've also brought in my own experience from working at Oxford Place and from working closely with colleagues in Buckinghamshire. And together we wanted to look at areas of the service we could improve in development. So I'm hoping to use this time to reflect on some of the highlights from the report since the Q1 data was presented to you in June. I do hope this answers some of your questions, but please do ask me more at the end and I'll do my best to respond. Okay. So it was previously highlighted that data showed Berkshire West had some variation when compared to other systems, particularly around referrals and eligibility. Using that feedback, and as summarised at the previous meeting, we've created a central referral point for all CHC checklists. This is staffed by a team of clinicians and administrators from across the 3 neighbourhood teams to bring about greater consistency in our process. We are also working closely with East Berkshire to make sure our processes are aligned where possible in preparation for our move into Thames Valley ICB. The creation of the central hub has allowed us to take a much deeper look at referral activity. And what we can see is that referrals are mainly coming from local authorities and community providers, and that those coming directly from the community are more likely to be from people who are self-funding their care or individuals who don't currently have social work involvement. So looking at the Q2 data referrals for Berkshire West, we remain comfortably above the 5th percentile for new standard CHC referrals per 50,000 population and are on par with other place bases within the ICB. At the end of Q2, you'll see the snapshot position shows that eligibility per 50,000 has risen to 12.8. Whilst we recognise that this is still lower than some other regions, we do want to make note that the direction of travel is in positive and improving, and I think that's a really important takeaway. As we move forward, the next step is to bring fast-track referrals through the central team. You'll also see on the slide shares, when we look on the year-on-year comparison for fast-track referrals per 50,000 population, Berkshire West has increased to 21.4. This reflects a position in line with the average referral rates across the region and is similar across all places within the ICB. The number of people eligible for fast track in Q2 is also aligned with expected eligibility per 50,000 population. I'm also pleased to say that since the last meeting in June, the healthcare contributions policy has been developed and published alongside a developed and published interagency disputes policy. The slides we provided report that 28 disputes had been completed, and at the time of writing, this has now increased to 33, with 75% resulting in the not eligible decision being upheld. The local resolution overturn rate matches the national benchmark, which I hope provides reassurance that decisions are appropriate. If access were being inappropriately constrained, we'd expect to see higher appeal success rates, and that's not what we're seeing. We'll continue to work closely with our local authority partners to resolve disputes in a timely way. By following the dispute policy and agreed process, this has supported close partnership working with our 3 local authorities and has allowed us to agree healthcare contributions following the not eligible CHC decisions. We hope this will continue to strengthen our collaborative working relationship as we navigate the changing landscape across both health and social care. Thank you. And any questions?
Thank you for that. Councillor Kander, you are questioning something?
Yeah, because pack I'm looking at seems to have 3 pages to do with agenda item 7, one of which is a slide. You were talking about 12%, you were talking about across the years, and I don't see that on the slides.
That was requested after these were submitted and will be sent in, so you should receive those further slides with that data on.
Yeah, I think we did have a question about the data, that's true, because it's presented in a very different way to the data that was presented at the original meeting. And I think that's probably what you're responding to, but members would not have seen that. So that's...
Because the issue I've got as well is you're talking about Berkshire West as a consolidated view, but in West Berkshire seems to be very small grey parts that don't seem to hit anywhere near a lot of the others. So does that mean that we West Berkshire are behind, although Berkshire West is not? That's why I wanted to understand, because the way you were talking through it didn't sound like we were.
So the data that you've got access to on the slide, so you have Berkshire West consolidated, and then the grey bars are Woking and Reading and West Berkshire as separate small areas. So if we look at West Berkshire consolidated, that's the 3 local areas altogether.
Yeah, but it doesn't tell me how West Berkshire is performing.
Yes, is that to do with numbers? That's not to do with numbers. I mean, that always seems to be the case, that West Berkshire is bottom, and that's been our ongoing issue, really.
So if you look at which we will, as I said, we will submit the further slides. They were requested after we'd submitted this pack, so you'll be able to see on there. But if you're interested also in the standard CHC referral conversion rate, we're in cluster 3 of the ICB regions, and actually Berkshire West is sitting 4th from the top. So we have moved up.
Berkshire West. What about West Berkshire? Because I know we need a consolidated view, but we're also sitting in West Berkshire.
Okay. That data I can come back to you with. We can
Thank you very much. I mean, this was about wanting local data, I think, which is what we wanted from this presentation, but we appreciate the ongoing work. I've just got some probably quite simple questions here. You talk about positive and negative referrals. I mean, I'm not absolutely clear.
Oh, sorry.
means and a high number of cases that aren't eligible. Surely that's a bit of a concern. The people are being referred. I think it was 75% somewhere. I think people are being referred and then they're not eligible. Does that mean that GPs need training, that they're actually passing people on, that they should? But that's a total waste of time because they have to be seen when they're not eligible. So, you know, is that a training issue?
So I'll just separate those questions out because I think you're referring to, so the 75% is referring to interagency disputes. So that's disputes between the local authority and the ICB. So that's, they've already had a checklist come in that's positive for assessment and we've assessed, but there wasn't a recommendation made. So then that goes through our local dispute policy. So that's where that figure has come from. With regards to the checklist being negative and positive, when a referral comes in, if it's positive, then they'll go through for assessment. If it's negative, sometimes they're awarded a healthcare contribution funded nursing care, dependent on their locality.
That's the FNC at the top of the.
Yeah.
Okay, that makes sense. Can I, Councillor McCrow? Yes.
Yeah, looking at the kind of graph of positive referrals, I noticed that West Berkshire was at just under 25%, whereas Reading is 40%, and Wokingham, which I would thought Wokingham was a kind of comparative kind of demographic to West Berkshire, probably a bit more affluent than West Berkshire, but not that much, and they're just apparently just under 40%. Is there anything that would account for that difference, please?
That's something that I can look into further and get back to you. We are rolling out training across all areas, which will help with the referral rates.
So are we saying we think this is cases being referred that shouldn't be, or as opposed to kind of referrals that we're refusing for? I can't think of the right terminology really, but because we've had a history going back decades of having a very low grant rate of continuing healthcare. I remember being on a scrutiny committee here some considerable time ago when we were kind of bottom of the National League, and things didn't seem to improve for a very long time. So is it a question of people being referred that shouldn't be? Is there something wrong with the referrals, or what is it?
No, the data shows that the referrals are the correct referrals. When you look at the conversion rate that's come up, any kind of more data I can look into and try and get that back to you. And I don't know if Daph wants to come in. Might be able to give you.
I was just going to say to panel at this time, obviously the checklist for NHS continuing healthcare consideration is deliberately set at a low bar, so that you will expect more people to come in than are eligible, and the expected conversion rate is around 22%. And then what we're finding is that now the Berkshire West area is now increasing more towards that percentage. So actually it's improved quite a lot over the last year. I think because of the smaller referral rates, it takes a long time for that to catch up with sitting within the national average because of the people who are already in CHC to even out those numbers. But there is some further data that we can share with you afterwards that explains the situation a little bit better, if that helps. I hope that's helpful comment for you.
I think the extra data would be quite helpful. Thank you very much.
Yeah.
Thank you very much for this. Councillor Kanda, I will ask Paul Coe to comment in a minute, but you have your question. Go on.
Just to pick up on Councillor McCrow's question, really, which is, I mean, long story short, if 100 people in West Berkshire and 100 people in Reading all make the application, there must be some difference if the tick sheet is exactly the same. So is it socioeconomics, or is it the way we approach things in West Berkshire compared to Reading? That's kind of where I think you might be wanted to get to, Councillor McCrow. And that would be important for us, because if we've always been down the bottom, is there something fundamental that we as not an organisation, but as an area are doing incorrectly or could do better, or that Reading is maybe doing something different? maybe we could learn from them if there is no real difference. That was it.
I think that's interesting. Did our presenters hear that? Does that sound useful, comment or relevant?
It's useful and relevant, and that's something that we will be looking into further, working alongside population health, looking at demographics and referrals.
Thank you very much, and thank you, Councillor Kanda. Paul, can I just ask Paul to comment, Stephanie? Because all right, you go ahead. Go on.
No, I just wanted to make a comment that I was hoping that Paul might answer. My only question is, do you feel that we are now being treated more fairly than we have been since Councillor Aaron Macro has said over the years we appear not to have been treated very fairly in this situation?
Thank you, Councillor Stevenson, for bringing Paul Coe in, our Executive Director.
Thank you, Chair. I think Daphne's comment is a significant one in terms of the changed practices taking time to flow through into the data. When you look at the nationally published data today for Q2 is online, we are still third from the bottom. Berkshire West, that is, we're still third from the bottom. What I hope that changed practices will flow through and will start to look different. I think it's fair to say we're still in active dialogue with Bob. I do think the changes in terms of having a centralised team should bring consistency, and that's really important. I think that's the area that we worried about. I suppose I would say to the ICB as well, you please do tell us how because I think there is more, what's the right word? More motivation in the ICB to get this right, but we need to do this together, and we'll be open to that kind of that comment. But coming back, what kind of referrals are we sending in? Are they the right kind, and how do we make sure that it's the right kind of cases? So, in answer to Councillor Stevenson's question, I have some gentle, cautious optimism.
Oh, gosh, that sounds positive. Isn't that amazing? I saw Daphne nodding while you were saying that. Do you have any comments in response to that, Daphne?
I do. I mean, I think, and Paul, and thank you for all the work that we've done with yourself particularly over the last 18 months since I've been within Bob. But what we feel is this is a good news story. It's not the best story, but it is a good news story. And that I feel as though we've made inroads into the areas that we needed to. So getting on board with a centralised hub. The joint training is something we're really keen to roll out. We really want that engagement. And I think that we've proven over the last 18 months, when we have done things joined up with the local authorities, that we have made, good progress in those areas. We've put the healthcare contribution policy out there for joint funding, and we want to work with the local authorities to refine that. It was put together, it was distributed, and we are looking forward to having feedback on that at the end of Q4. And obviously in the meantime, if that helps. And I also, we have the disputes policy, and I'd really like to get that with some joined up conversations as well with the local authorities, so that we can get to the right timeline, so that we're not having the disputes breaching, the expected timelines as they do currently. So they're all really good news things. We've put things in place. It's now about operationalising them. It's about having the joint training, and it's about committing together to make that all work. So yeah, and I hope that, gives you that gentle reassurance that you want, Paul, there, because I do feel it's a good news story all round.
Thank you very much for that. I've just got a question and then a comment before we move on.
Yeah.
In the initial report in June, you talked about in the list of action points, establishing a pilot to consider the unmet health needs for children and young people who do not meet the threshold for children and young persons continuing care. And there's no mention of that in the equivalent page 48, future delivery. Is that some work that's been done? or is it sort of incorporated in different terminology? Do you know anything about that?
Yes, so the children's and young persons guidance is different to the adult framework, which is the measures that we've been talking about today and the data we've been talking about today. There is, as you probably aware, a year ago we started the BW Children's and Young Persons panel, and that received quite a good lot of feedback for the local authority and for Bob working together on that process, and that is ongoing work. Obviously, as we move into the new ICB, the children's continuing care is now merging and aligning together to give a one process for the new Thames Valley. So it is obviously very different to the adults framework, but it is still operating, and it does have its own programme of work where the processes are getting consistency for all areas. So I haven't got anything in depth to talk about on that, but I can assure you the work is going on, and we can bring more on that subject if you want us to.
Thank you very much. That's that explanation. Councillor Foote, yes?
Thanks very much, Chair. I wonder if I could have a few points of clarification, and I've just got one other point. The first one is, you've spoken already about the Thames Valley ICB, which is, I think, quite new. Can you tell us where, what geographically, who does that include? We know that Bob is Buckinghamshire, Oxfordshire and Berkshire West. And of course, it is extremely confusing for all of us in West Berkshire that we talk about Berkshire West as far as a health authority or, as part of Bob. So my first question is, could you tell us what consists of the Thames Valley ICB, please?
So basically, it's Bob plus the Berkshire East element of Frimley.
Thank you very much. That's great. I think actually that's reminded me. The moment you mentioned Frimley, I have heard that before, so I'm sorry I'd forgotten about it.
No, that's fine. Happy to confirm that for you.
Thank you. That's great. And when is that live? Is that live now?
So at the moment we're working in the cluster, and then that is a go live date of the 1st of April 2026. Yes.
Thank you. Okay, you mentioned the Berkshire West Young People's Panel. Could I ask who consists, what's the makeup of that? Do we have young people on that panel?
So that panel is the 3 local authorities. So it's Reading, Wokingham and Berkshire West Berkshire, I should say, shouldn't I? So that's the cohort. It's split into the 3 areas. So each area present their cases to that panel, and it's run by or chaired by Kevin Gordon. And then Jenny from Continuing Healthcare Children's, Beeham, she presents for the ICB, and then the cases are worked through that at that panel. And that's now been running a year.
Okay, so that's a panel about cases, I guess, is it?
Yeah, young people under 18. Yes.
I see. Thank you very much. And then my last point was just to, being this is my first health scrutiny meeting, and Councillor Kander and Councillor Macro, I think, made some very important points about the fact that, once again, we're West Berkshire Council, and when we're talking about Berkshire West data, we do need it in that granular detail so we know what our district, West Berkshire, is doing in that Berkshire West sort of context, if I may. Thanks.
Yeah. And that data will follow after. Yeah, we have that for you.
Thank you very much for those questions, Councillor Foote. I think this is something that obviously we need to keep track of, and there are several things where you said we'll get back to you. I think we probably do have a 6-monthly update on this matter, don't we, Vicky? Vicky's nodding. So we'll be hearing more in 6 months' time. Before we move on, I'd just like to say, obviously, thank you to our 2 presenters. Just to make members aware that we've been talking about the new ICB, and this reorganisation means that there's been 50% cuts to the ICB. So they are struggling with cuts and with sickness as well. So we are quite pleased to hear and grateful that among all of that, that the budget for all age continuing care has been ring fenced. And so we're grateful for the continuing work that's going on there. And I'm sure Paul Kerr would probably back me up on that. He's nodding. So thank you very much for your presentation. No more questions? No. And I'm sure we'll be seeing you again in the future. Thank you very much.
Thank you.
Thank you,
Okay.
Chair.
Thank you. Bye.
Thank you. Bye-bye. Bye-bye. Now we'll move on to item 8, which is Adult Social Care Quality Commission progress. And this is an update following the local authority assessment in February 2024, with a view to the further assessment coming up in 2026. So Paul Kerr will be presenting on this. Thank you.
Thank you, Chair. And yes, it's quite a high-level paper. It was a difficult balance to strike between high level and the oodles of contextual data that would have given you the fuller picture. I hope I've struck the right balance. The key messages for me, I guess, are yes, we were inspected, and I should say it's not just an inspection of adult social care; it's also our commissioning function, which links in, and other aspects of council functions as well. You know, how is the whole delivered? We've been working hard since that inspection visit and the report that followed. And the key messages I guess I want to give to you are as follows. We have completed the great majority of the improvement actions that we identified, either through the inspection itself, or through our self-assessment, or through things that have come to light subsequently. There are still some areas where we have not been able to nail the improvement actions that we wanted to. The principal area of that is related to the commissioning of the kind of market management and the commissioning of care from the external independent sector. I am somewhat reassured that the commissioning team within the council has now completed has set out a new structure and is going through that process of consultation and putting into place that new shape, which should enable us to do that work more effectively. There are a few other items that we need to pick up on, some of whom are stuck because we are going through the implementation of a new case management system. So some things are just going to have to wait until Mosaic arrives with us. So broadly, good progress, few areas of deficit, but some for good reasons, and some are underway now that should be ready by the time that inspectors next come and visit. Worth me saying, we don't know, of course, when they will next come. They are undertaking a review of their processes currently. Their proposal will go to the Minister in April, scheduled to go in April of 26. And so we should get a clearer steer about what the assurance regime will look like after that date. The current indications are broadly, it won't be massively different. What we don't know at all is the timing. In other words, we don't know how they will prioritise revisits. They have in December, in the current month, we know that they have undertaken all of the site visits to all local authorities. They haven't published all of the reports, but they've seen everybody now. So there's a good chance that they'll be with us spring next year, May, June, maybe. And are in the January to March months, we'll be doing our readiness activities, we'll be writing our self-assessment, we'll be collecting our information together so that we're ready for if they do come. But ultimately, as I say, we don't know how they're going to prioritise their second visits as yet. Happy to take any questions.
Thank you very much for that, Paul. I note on page 52, where you're talking about open items, You say market shaping, commissioning, care quality is one of the major issues, but you also mentioned safeguarding, and there's a number 6 beside that. Does that refer to individuals?
No, that's and there is a line. I was careful to add it to say those improvement items in the category of safeguarding are not putting anyone in danger. You know, people are safe. This is principally about changes to our flow that we can only deliver in our new system. Yeah, and I should. Sorry, this is going slightly off topic, but we have to institute a West Berkshire Safeguarding Adults Board as of April of the coming year, because our tri-borough arrangements will be ceasing because Woking Borough Council have withdrawn from that board. So, but no, please be reassured that the improvement items are not placing anybody at risk.
So, and in relation to that, page 53, you talk about, I mean, I've got a question about what RACI means, and also you talk about mosaic. Now, I know we're going to hear more about mosaic in future, but I don't think I think Councillor McCrow does, but he's probably the only one that understands what mosaic is. So if you could say, what is RACI, and briefly, what is mosaic?
Mosaic is, so we currently have a case management system called Care Director. It's very old. We are in the process of replacing it. Mosaic is the replacement case management system. So it's used widely by other local authorities, and we are in a program of work. Our target implementation date, go live date, is April 26. So please, could everybody keep your fingers crossed? And what does RACI? Yeah, sorry, RACI. Apologies for that. RACI is kind of a it relates to responsible, accountable, consulted, and informed. It's basically about making sure that everybody in a system knows what the role is that they're playing and who's talking to who. So it relates to decision pathways. Yeah.
Okay, thank you for that. I mean, it would be useful if, whenever we have acronyms, if we could, I know it must be boring for you, but if there are routinely used acronyms, we could have just a little sort of permanent little table at the back, and then just the additional ones added, because we're constantly, every meeting, I think one or other of us is asking a question about this sort of thing. Councillor McCrow.
First of all, I'd like to congratulate the service on achieving good. I do remember, I think there was a little bit of trepidation in the run up to it, because West Berkshire was one of the first, I think, if it wasn't the first. There have been, I think there have been some pilot ones, but this was almost the first real assessment. So congratulations. On the acronyms, then there's something I've been raising at various committee meetings, because you know, the services know what they mean, but you know, for each individual member to go and look something up as they read the reports, it's a bit of a waste of time. And of course, for kind of members of the public who might be listening in, then it's equally meaningless. So if we can do something on that, that'll be great. Thanks. I did when I was portfolio holder, I did kind of build my own acronym list based on something that the service gave me. So I'll circulate that, but I'm not sure that RACI was in it. But yeah,
The old Newman's almost coming along, but that would be useful. Thank you, Councillor McCrow. Maybe if you do that, that would save Paul a piece of work, possibly, if you've already got it.
I do have an updated version, Alan. I will. But I absolutely apologies again for letting that one slip through the net.
I don't see any hands up around the table, but the only other thing I was going to mention was you talk about a task and finish group, which is obviously around the things that you've highlighted as open items needing progress. Would it be appropriate for that to come to this committee, the results of the task and finish group? When will it finish its work?
So this effectively, this report is saying what has that task and finish group done, and it's made up of adult social care, commissioning, finance, quality, and so on. So when does it finish? Well, essentially, when we are next visited, we will get another report and a whole new set of actions, I'm sure. So it's a bit of a rolling program. And I think if we can, what I wanted to give you today was a sense of how are we doing in relation to those, significant number of actions. Whilst although we were good, it's clear that there was work that needed to be done. How we were getting on with that work, and I would, if it's helpful, expect to do something quite similar in terms of the action. The action plan went to our executive briefing, and I think it was probably reported through the exec actually when we had the final report. But I'm happy to bring updates here as we go through that cycle again.
It would be useful to know what's going on, but even maybe we don't need to bring it back to committee, but maybe we just keep track of what's going on through Vicky. Any questions? I can't see anything. Okay, well, thank you very much for that, Paul, and we'll obviously look forward to constant improvement. So the next item is item 9, adult social care client level data set, and we've got Barbara Billett here for that, who's quality assurance manager, and she's going to provide an overview of her report. Now, just to tell members that obviously this is for information. It's like a sort of training session in a way, because we're all new to this. And I must say, my head just spins when I see all this data. So we'll see how we get on. If we feel that we need more than you're providing today, I think it might be an item that we ask for more sort of input outside of this meeting, possibly, because I think probably this and other things related to adult social care, we probably do need a little bit of extra training. But over to you now, Barbara. Thank you.
Thank you. I'm going to share the slides, hopefully. Hopefully, some of you will have had the opportunity to look at these anyway. But essentially, you're correct. This is an opportunity for us to socialise adult social care data that's been reported back up to the Department of Health and Social Care. Bearing in mind your previous comments, I'm hoping I haven't used too many acronyms that are not explained. But I can correct that if they are. So the client level data set, I would say, is in its early years. It's only been required statutorily for 2 years. So this is its second year. And actually, it's the first year that it's been published in isolation. So previously, we've used our previous framework, which was short and long-term support framework. So the data that's being published from the client level data set is very, very early. And there isn't a lot of data yet, but it's evolving. So it's to bring you up to date and bring you up to speed with what kind of information we are submitting up to central government and the information that we're expecting to be returned. So this is really just a kind of brief overview. So if I go too quickly or too slowly, then please push me on. So the client level data set is essentially activity in relation to adult social care that we are providing back up to the Department of Health. It's reported every quarter. So for every single quarter, we report a rolling 12 months worth of data, and that data is transformed by the Department of Health. The data is going to be used to inform adult social care outcomes framework, so the national KPI data set that is published by all local authorities in terms of certain key data information. And the CQC, we just talked about the Care Quality Commission coming back. They use data from this data set to understand our activity and understand our performance. The other thing that's critical about this data set is that part of this data set is including the NHS number, and there is an intention long term to overlay that with health set data. So that's the long term intention. It hasn't really started yet. So in terms of the data that we provide, it's split into really 4 events, really. We report in relation to request events, so those people that come to us and ask for our help, what are the volumes of those request events. The numbers of assessments that we provide, and they're split by financial assessments, short-term and long-term assessments, the number of services that we provide, and you can see on the graph here, the number of services is quite high compared to the other events, but then that's because it's for each service, we provide a line per service. So if someone is receiving home care and daycare and transport, we will provide that as 3 different events. So as a distinct account, then you have to look at it in terms of a distinct account. And then we provide review events. Got a question?
May I?
Councillor Jeffrey.
Just so that I'm definitely on stream, is Section 42 investigation a safeguarding investigation? And if it's not, what is it, please?
So Section 42 is a safeguarding investigation, correct? You're correct. Section 42 is a safeguarding investigation and it is not included in this reporting framework because safeguarding is reporting as part of what we call the safeguarding adults collection and is a total data set that is separate from this, that is reported separately. Okay.
Can I ask, page 59, what AMPH work? What is that?
It's AMP work, so it's mental health practitioner assessment work. So we have a duty, so that we have adult mental health practitioners in the social care team that are required under law to provide mental health act assessments where required. So they, for example, may lead to someone being detained if someone is suffering from mental health crisis, illness. Paul, you might want to expand on that definition.
Spot on.
And page 60, NRS insolvency. What is that?
So that's NRS is was our equipment provider, a Berkshire-wide equipment provider that in the summer of this year ceased trading. So that created a huge amount of issues, I guess, in terms of replacing that provider service. So we now have Millbrook in place, but that transition took a little while. So suddenly we had our NRS provider, Nottingham Rehab Services is what it stands for. And they provided all of our equipment across Berkshire. It wasn't just West Berkshire. We held the contract locally. And suddenly they went into insolvency and it hit the national news actually on the BBC. And because of that, suddenly there was a huge amount of work in terms of how can we identify a provider that can provide those urgent pieces of equipment that we need to provide people to help them with their daily living tasks. So there was a massive piece of work to look at that. And there was a period of time when NRS provided what we called a trusted assessor process. So we didn't have that service anymore. And also the equipment that was provided for a period of time, I think we're back up and running now, was only critical emergency equipment, not some of the stock equipment that we now have available.
Did you have a question?
Well, it was a comment really, Chair, if I may. It's just that I know my executive colleague, Patrick Clark, Councillor Clark, who's adult social care. I think it's worth, I'm sure if he was in the room, he would do this, but it's worth acknowledging there was a huge amount of work that the officers did. And I think it's worth recording that there wasn't any impact on the users of the service, which I think is a massive credit to everyone concerned. And I think it's worth actually recording that and you know, if I may, through Patrick, on Patrick's behalf, I should say, thank everybody involved in all the work that they did, because outside you wouldn't have noticed the difference, but there was a lot of work that was done by this council to make sure it all went smoothly. Thanks.
Thank you. I think I do remember being informed about that, actually. Yes, so thank you very much for explaining that and for your comments, Councillor Foot. I was just, obviously, we've got this mosaic as mentioned again, which just shows how important it is, and the importance of data. And you mentioned linking to health data. And obviously, we've got to make sure the data is reliable. Otherwise, we'll get into a right whole muddle, won't we? And when we've got 2 sets of different data, I suppose that having the confidence that you're actually all working in the same.
Yeah, absolutely. I think for the first time we are providing the NHS number alongside our data sets, which will, I think, be used in the future to look at how that can be overlaid with health data sets and look at how the integration agenda can be pushed forward. It's too early yet, it's early days, but the intention is definitely there. And certainly in terms of some of our Better Care Fund data sets, for example, I can see that being pushed forward and how that can be worked together in a more integrated way. Yeah. So the scope of this is actually, has got some kind of long-lasting potential. So we're the early stages of it, but we're prepared, I think, in terms of the data that we provide and our understanding of that, and how we can use that to work with our health partners as well.
So that can possibly link into the Better Fair Fund, which we're discussing next. Can I just I can't see any hands up now. Page 67, there's a mention about high number of young adults in our area, and I actually wondered whether is the presence of Mary Hare and Priors Court got something to do with that? Because people come in as children, and then they possibly stay with their families as young adults. So is that an issue?
So yes, I think page 67 is the comparison information on long-term services. So one of the so a lot of the data that comes from the Climate Ever data set at the moment, we haven't got much benchmarking data. The exception to that is the long-term service numbers, which we have been providing routinely as part of a national data set for some years. And so therefore we can compare ourselves nationally with where we sit with other local authorities, and the graphs I provided are in the region and the England average. And if we compare per 100,000 population, so it makes us comparable, for those that we provide a long-term service for 18 to 64-year-olds, we are quite high. And actually, if we looked at the 18 to 24 data set, which is not in this report, but I have available, we're even higher compared to the national average. And you're right, we are looking and exploring why. And is it because we've got some local really good specialist schools, people move here for that provision and then they end up staying here. And so they become ordinary resident to our local authority, and they become, we are requiring adult social care support. If we look at the 65 plus though graph, I would say that's quite encouraging, because the 65 plus graph, we're a little bit lower than the England average, probably in the middle of the southeast region, but actually we know our population is much higher. We have a hugely growing population of 65 plus people. So actually the fact that we're maintaining that and allowing, encouraging and providing that support to those that need it, but we're not drastically high, means that that's a good thing for West Berkshire. We have to provide support to those that are the most vulnerable and need it the most, and we try to do that in the most fair way under the Care Act assessments and through the provision of support that we track through various monitoring processes within adult social care.
Very much for that. I think Councillor McCrae.
I wasn't sure whether we should ask this now or whether go through the No, thank you. Sorry, I wasn't sure whether to raise this now or with you going to present the rest of the pages.
I'm happy to take questions. People have seen them.
On the request events page, it says 54% of requests were resolved with no further action. And then going on to the next chart, it says of assessment events, 34% resolved with no further action. It sounds like there's quite a large number of clients who come to us and we resolve with no further action at all.
So I'm guessing no further action may be a wrong term. No ongoing support. So those people that come to us, especially at request events, one of the things that we try to do, especially on the front door, is provide people some really good information and signposting. And that's seen under the Care Act, actually, that's seen as a requirement that we're required to do. And for many people in our area who are potentially self-funders and are able to provide their own support, if they're supported with navigating the health and social care kind of network, we can provide that support. It means that we don't, as a local authority, have to provide ongoing support, but we provided good support at that first point of entry. Equally, after an assessment, we may provide a piece of equipment, which we consider quite preventative, or we may provide, again, a very short-term service to help people back on their feet and get them stable again. But when I say no further action, it's no further ongoing support from adult social care. So no further action is probably the wrong word, it's no further support. So we do everything we can to try and provide support in a strengths-based way at the point of contact and that initial conversation, because we want people to try and help themselves, because we only have a finite pot of money. So we can do everything we can to work with people to help themselves and give them some really good equipment, information, short-term service to get them stable and safe. And it's only those that then go on to need ongoing support that we can kind of progress down the long-term services and ongoing support needs. Is that a reasonable explanation?
Yes, thank you.
Thank you for that. Any more questions, members? I think, Councillor Steve.
Yes, I suppose it's just a comment, Chair, that on one of the pages, page 64, the service events, I noticed that we've got service users by age and gender. And apart from the fact that more females seem to live very, very long, we've got 154 people over 95. I mean, is that average for the country, or are we just all of us getting longer lived, please?
Interestingly, I'll come back on that. When I first came into adult social care a few 20 years ago or so, we didn't support that many people that are over 100, and now there are lots of people, I would say, that you're seeing more and more in their 90s, 95 plus, that we are supporting. And I think that's a sign of the fact that we do have an ageing population, and we are seeing they are living longer, definitely. And therefore, you know, in some ways you could see if they come to us at a later age, then that's a positive as well. But we are definitely seeing an ageing population coming to us at a later stage.
And quite a lot of them are amazingly fit and active, and you know they're actually, you know, they are not sort of taking up a lot of care from the local authority. They are, you know, I mean, some that I know, I'm talking from my experience, and that's what we want to hear, isn't it? That people are aging well. Yeah.
And I think, you know, if you adult social care supporting people that with long-term support is a fraction of the whole population. There are many people living in their 90s that we don't see at all. So you have to keep that in mind as well. It's just a proportion of the people of the population.
Amazing how resilient some people are. I think we need to sort of pocket the resilience of some people or find out how they do it, you know, so we can spread it around. Just Councillor Foote. Yeah.
Yes, thanks very much, Chair. I think the point you made actually about the fact that we've got some, in the district, we've got some specialist units, and the point Barbara made, it is Barbara, made about the fact that families will settle eventually in the district. To me, that's really quite an important little data set that we need to capture, because it reminds me a little bit of the data, this sounds a bit grim, but the mortality data associated with certain hospitals that are specialist centres. So by definition, they get the most ill patients. And when you're dealing with a cohort of people that are sadly very, very ill, a higher percentage of them are likely to die. So on the base of it, the stats look bad for that hospital because, you know, they've got an increased mortality rate. But what people sometimes don't realise is that the patients that they're dealing with are very, very sick. So I think for us, if in the area we've got these specialist centres, it would be interesting to capture that data about, you know, the ongoing needs in adult social care, which obviously, as we know, can be extremely expensive. So maybe if we can get that granular level of information, it would be really helpful to bring back to this committee. Thanks, Chair.
Thank you very much for that, Councillor Foote. Yeah, and I would have thought that, you know, if we've got this special cohort, could we get some money to come along with them from somewhere, really? I don't know. Were you going to comment on that?
Thank you, Chair. If there is a special pot of money, I haven't identified it. We do have quite good sight of, I mean, we refer to a group sometimes preparing for adulthood or transitions, that small number of, relatively small number of people who are children who will need ongoing support. That number has grown really significantly over the last 5 years in particular. So I suppose there's a bit of a question about you know, some of the education facilities have been around for longer than that. So, it is true to say that is a group of that is a need which we are seeing on a national level, but West Berkshire is seeing more than our fair share. So yeah, we'll keep looking at it. We've got pretty good data at the moment in terms of what we've seen. Understanding exactly what's driving it is the tougher bit, but we'll keep looking.
Thank you very much. Did you want to say more?
I think just to summarise, really, it was an opportunity, thank you, for us to socialise this data and show you the information that's collected and reported. Certainly, we're early days, but as that information gets published, we'll be doing more benchmarking to understand where we position West Berkshire in terms of other authorities. And, there might be things that come out of that we can kind of share that may be of interest, and certainly we'll be looking to work with our commissioning colleagues about how we respond to some of that activity and the kind of demand that's in place. So thank you.
Thank you very much. I mean, that was very interesting. I must say, data is one of the things, and interpreting and understanding it, is one of the things I struggle with. So, I mean, I have mentioned to members whether or not we think we need any more sort of training or information sort of between meetings outside of this, and I think this might be an area, but I know one or two members have got back to me on this, but it would be good if members have a think, do they have a particular issue that they'd like support and help with? Is data like mine, is that one of them? And I know that that Paul and his team would be happy to assist us so we can make the best use of these meetings, understand what we're talking about better. Okay, and because we're all in a sort of learning process, having only recently taken on adult social care under this committee. So thank you very, very much for that. That was actually more interesting than I thought it would be. So thank you for that, and thank you for both for your comments. Okay, thank you. So now we move on to Paul and the Better Care Fund. Okay, thank you.
Thanks, Chair. Yes, so some of you will be familiar with this Better Care Fund. It's a pot of money, which is the intent behind it is to make sure that local authorities and health partners work effectively together, by giving us a shared pot that we have to agree how we're going to use it. Been around for a good number of years. I think we here locally get good effect from this shared pooled budget. I'm afraid the report you'll see doesn't have. There are some data gaps. Some frustrating data gaps, so it's a bit of a partial report. Worth me saying that this reporting on the Better Care Fund goes routinely to the Locality Integration Board, which is a subgroup of the Health and Wellbeing Board. And historically, this sort of report has also gone to the Health and Wellbeing Board, but I appreciate, going forward, we want to take a different approach there, don't we? So this is essentially a quick update on where we are at the moment. You can see that there are some key metrics that nationally we're expected to use the Better Care Fund to achieve. So trying to keep people away from hospital, trying to make sure that they're discharged from hospital in a timely manner. And the other key metric here is to try to make sure that people don't go into care homes unnecessarily, particularly from the hospital pathway. So the good news is we are doing well on that last metric. We are not just firing people straight into a care home. That's good. We have some data gaps though in terms of the other metrics. The discharge piece, the delayed discharge piece, we're currently not on track to meet our target. I think going back to the thing we were talking about earlier in terms of the NRS insolvency, there have been some problems in the system which mean that it's been hard to get people out of hospital quickly. So, for example, adaptations to people's homes and getting them the right equipment in the right way, and even just the fact that practitioners have been working around a problem rather than having a smooth process. So in terms of the use of the budget, we're on track to. There'll be a small underspend, but we can carry that over. And yeah, currently I think the relationship between health partners and the local authority in terms of the use of this fund are fairly healthy, fairly well managed. Thank you.
Thank you for that. I mean, this is a really important fund, isn't it? And it's one of the important to see that, the local authority and the ICB working together and a bit of integration, which we don't really get enough of. But you do talk about the technical issues, again, the data, and this seems really important. And is there any, how are you getting on there? Is this sort of improving? Is it a long-term issue? Because I mean, you're a bit stuck if you're trying to work and you don't know how well you're doing or where you need to put more effort in.
Yeah, I mean, Babs, I don't know if you want to speak particularly more about the data issues, but yeah. No, okay, that's fine.
There you go, sorry. So one of the data sets come directly from adult social care, which is the new admissions data. And we're absolutely on track with our target. And we've been working, or the team, especially the hospital discharge team, have been working really hard, what we call their pathway 3. So pathway 3 are those discharges from hospital that are coming out with the potential to need residential nursing care, about challenging whether it's appropriate for someone to have residential nursing care, or is there an opportunity for them to come home without that, with another package of care first. So that's really successful today in terms of that work. And we can see the new admissions have dropped in the last 12 months, which is great. The other data sets come from health. And I think it would be reasonable that actually, because of the changes with Bob at the moment, some of those data sets have been a little bit challenging to keep up to date with. So we heard earlier from colleagues in health, and they provide the other data sets that inform the Better Care Fund, and some of the changes with the BCF, with the Bob setup, has meant there's been a delay in some of that data, I think.
On the chart, the page for discharge delays, it says local data from Frimley suggests we're not on track. I wonder why the data was coming from Frimley.
Sorry, should I try and answer that?
Please.
Was that Helen? Was that?
Yes. Yeah.
Oh, Helen, hi.
Yeah, apologies. Sorry, I did have my hand up, but I just wanted to come in on the data issue, if that's okay. Oh, sorry, can you still hear me?
We can hear you. We're just getting your picture up, I think, because you're quite tiny on the screen.
Oh, okay. Well, just very briefly to say, so the changes that we mentioned to the ICB earlier obviously are still ongoing. So that will start to have some impact in terms of who does what within the ICB. We've had some changes to the production of the reports for the Better Care Fund, but the previous reporting is now being replicated. So the issues highlighted should be resolved from a local perspective. There is a national dashboard being developed for the BCF, and I think some of the commentary within the report actually relates to issues with that national dashboard. Those are still ongoing, but the local reporting that has been replicated should solve particularly the question around the data on emergency admissions. So I'm hoping the position has improved since that's stated in the report, but obviously continuing to work with social care colleagues around that.
Thank you. Is there any comments to that?
I'm still a bit puzzled about the reference to Frimley.
Oh, apologies. Yeah, I think what that is, so the report was reporting, the local reporting was previously produced by our commissioning support unit, but has now been picked up by the Frimley analytics team as part of the coming together of Bob with East Berkshire that we mentioned earlier. So I think that reference will be to the fact that the former Frimley analytics team are now producing the reports.
Okay.
Okay, Alan. Yeah. Okay, Councillor Foote.
Yes, thanks very much, Chair. I mean, as Chair of Health and Wellbeing, I sign off the BCF fund quarterly, and I can confirm what Helen's just said, that at my last meeting, it was frustrating that there were problems with the national data that was coming in, and so there were some sort of gaps on that. But the other point I wanted to make was that it's quite interesting because obviously the sort of end objective really is to try and keep people out of hospital, isn't it? It's to try and get people home when they've been in hospital, but also to try and prevent them getting into hospital. And being chair of health and wellbeing, it's quite a sort of privileged position in a way, because obviously we have close workings with public health. And you might have heard, and again, an acronym, OHID. It stands for Office of Health Inequalities and Disparities. And I believe it's OHID that fund predominantly, public health measures. Now, here we sit in a local authority where we have the capacity to do things in the public domain, because that's what we're here to serve. And it would be really interesting for me if some of that OHID money could be directed towards true public health measures. That's to say, measures that we can implement here at West Berkshire Council to keep people well and out of hospital. So, the Better Care Fund is an interesting body, because the figures are quite large and we do pretty well as far as I can see when I sign those figures off. But as I say, an ultimate goal would be to keep people out of that acute hospital environment, and that is an aim, I think, for all of us really to try and achieve. So that's an aim going forward.
I think Paul wants to comment on that, and then Dennis has a question, I think.
Thank you, Chair. I'm going to largely agree with you, Councillor Foote, but with a bit of a significant caveat. So what OHID would say is that the funding needs to go to the improvement of the population's health, and it cannot be used for the statutory functions of other government departments or local authorities or whatever. So it is basically and we've had a fair bit of real challenge from OHID on how we've used public health grant previously, and they're continuing to take a close interest in it, because there's this very fine line between what we must do and what will add value for the population's health. So yeah, we had a meeting of our local public health board yesterday where we were looking at how can we spend public health grant for the better health of the population. And there's always this practical consideration of, although actually, is this our duty anyway? In which case we're going to have to take the OHID view, which is you've got to do it and use this grant for other value added activity. So it's not as straightforward. I suppose what I'm trying to get across is it's not as straightforward as saying this will make people healthier, so we can do it.
That's interesting, but I mean, we're all struggling with funds. So if you can do it better, even if it's statutory, can you sort of make a case still for doing the things you normally do, but doing them at a higher level? No, is it?
It is absolutely and I suppose, without wishing to get too controversial, different regions of will have different views on what's eligible for public health spend and what's not. There is a person making a judgment about what's in and what's out, and we have to have that conversation with OHID. And there are some things are very straightforward, like funding smoking cessation, for example. Yeah, but then OHID has basically come back to us quite recently and said some of the things you have been funding historically, local authority, you should now stop because we think you should be doing this anyway.
Thank you, Chairman. This authority, to my mind, rightly so, has decided to continue supporting our resource centres. And with that in mind, and with being a Hungerford district councillor, we have a resource centre there. Is there any better use that we can make of those and promote them more and make better use of them within our communities?
Probably the best way for me to answer is we are currently going through a process for all three of the in-house resource centres of working out how can we make them as impactful as possible. As you say, we're committed to continue to run them. So, for example, can I say this? I think I can. We'll be looking to utilise some of the space at the Phoenix Centre to offer some family hub activities, for example. So a bit of a win-win, use the space better, deliver additional services. And we'll be going through that process with all three.
This is something obviously that we will, does this come to us annually or on a regular basis?
Every 6 months.
So it is okay, so we will be hearing more about this important work in 6 months' time. Okay, so now we have item 11, which is the Bob ICB update on children's mental health and emotional well-being. And we have Layla Johnson, hopefully, and Nikki Cartwright from Bob ICB to give an overview of their report, which you have in your papers. And this is an update. It's called an update. It's following the work of the task group on children's mental health and emotional well-being, which we referred to earlier. And that was set up because of concerns about work, the way things were with children's mental health. And this is the ICB telling us about, I think it's a start of some work or review that they're doing. So it's just the beginning of the work. So we'll be hearing more in future. So we'll be hearing from them how this is going. So we've got Layla and Nikki, hopefully up there.
Thank you, Chair. Layla's going to talk you through the CYP mental health item, and I will talk to the dementia paper.
Yeah, so the paper sets out the process around the review of children's mental health service and emotional mental health services. This quite rightly was part of the sort of stock take session that we did a few months back. I'm hoping that the document is self-explanatory in terms of the review. So I don't know if there's any particular questions around the review and where we're at. We're expecting the review to conclude in March. And what I can confirm is got very good engagement with West Berkshire colleagues in children's services and in education that are supporting the review.
Thank you very much. Can I ask if you referred to the work that our task group did in putting your report together? Is this assisting? Is it feeding into the work that you're doing?
Yes, it's very much assisting. This work really originated as part of a contractual arrangement that the ICB has with Berkshire Healthcare Trust. We recognised that the mental health service that we're commissioning was overdue for review. So this forms part of that review and the wider piece of work around the pathways that children sit in, both to access mental health support, but also the wider sort of emotional well-being offers that exist in Berkshire West to ensure that children don't fall through gaps. And obviously the future is looking at family hubs and youth hubs, and where mental health and emotional well-being potentially will sit in some of those new arrangements that we're working towards.
Thank you. Can I ask, there's a bit of confusion among us, because on page 101 in Roman numerals 4, you talk about mental health and well-being needs in Wokingham. Is that a misprint? 101.
Yes, I'm sorry. I think it was meant for West Berkshire. Apologies. We're doing the review across all the local authorities.
Okay, and so you are actually sending this report to different areas. Okay.
Yes, correct.
Just clarification. Councillor Kanda.
That was going to be my question, but also whether or not they're using the West Berkshire data. So it's not just a typo in the report rather than the application of the data as well.
Did you hear that?
Yes, so we have been using data, so partners have helped submit data to the review, and it's very much a sort of joint piece of work, understanding what the activity levels are in the different pathways and what the level of needs are.
No, it was more the point that if you're doing a West Berkshire report but referring to Wokingham, is it just Wokingham is a typo, or have you also been looking at, is the data Wokingham data? That's kind of the question I was getting at.
It should be Wokingham specific, West Berkshire specific.
Okay, that's reassuring. Thank you very much. Councillor McCrow?
Thank you. In section 2, the case for change, it says in the first paragraph that the latest data with 2023 reveals that 1 in 5 children aged 8 to 16 now experience a probable mental health disorder, an increase from 19% in 2022. So an increase from 19% to 20% doesn't sound very much, and doesn't seem to correspond with what I've been reading in the press about significant increases.
So I think the increases are in a wider context. So the first national survey took place in 2010, and that suggested that the numbers were 10% that had a probable mental illness. And what we've seen throughout the years is a growth. And I think partly we probably understand the numbers a little bit better, but what we're also seeing an increase demand coming through and increase mental illness amongst our young people, which is quite concerning.
So we're increasing, doubling in just a few years, basically.
Yes, yes, and almost as close to adult mental health figures now.
Thank you. Obviously, this is early days with your work, and we see that it's going to be completed in March. Are you aware of that we have a Children and Young Persons Scrutiny Committee, which is new to the council, relatively new. So hopefully, will you be communicating directly with that committee as well? I mean, we will liaise with them to some extent, but I think this is something that they should be aware of, and hopefully in future might receive your report. And certainly when it's completed in March, I think it's important that not only ourselves, but Children and Young Persons Scrutiny are aware of your work as well.
I think we can confirm we'll be very happy to present this work to that committee.
That would be really, really useful. Thank you very much. Do members have any further questions? Thank you. So thank you for giving us that overview of your report at the start of the work, and we look forward to hearing more about it in March. Thank you very much indeed. Thank you. Thank you. So now we move on to, where am I? Okay, yep, just getting the paper. So item 12, dementia. Okay, so members will be aware that we had a report on dementia at our September meeting. Paul presented. Unfortunately, the ICB wasn't available then. So this is the Bob ICB report. And we'll sort of try and link the two. So this is a brief overview of the report in your packs on dementia. And then we'll see whether we have any questions to clarify the report. Thank you. Over to yourself.
Thank you very much, Chair. So I'll just give some highlights from the paper. So you'll see from it that West Berkshire has a high prevalence of dementia. And I think the paper explains the factors which we think are influencing that. You'll see that we have waiting times for our memory clinics, and we have long delays in those clinics, and you'll also note that West Berkshire is the highest in terms of volume. We're looking to improve the performance of our memory clinics and work towards the 18-week referral to to being seen, which is the standard for other NHS services, and that's part of the work that we're doing. You'll also note that with our post-diagnostic support, West Berkshire is 69 days, whereas you'll see that in Reading it's 146 days, and it's thought that the reason for that shorter time in West Berkshire, although I'm sure people would say that is still too long when you've been diagnosed with dementia, is probably because there was £80,000 invested from the Better Care Fund into the Alzheimer's Society contract. We think that's what's contributing to those shorter waiting times. In terms of our next steps, we're mapping our patient journey, really keen to see where we can improve it, what the bottlenecks are, what the best practices that can be replicated in our services. We've, as an ICB, we have Dr. Sian Roberts, she's leading our dementia work, and then the West Berkshire, which sits within Berkshire West work, sort of snuggles into that. The teams have just completed something called the Dementia 100, which is about, it's helping us identify what the issues are. We've identified some of the other key areas for further exploration, which are listed at the bottom of the report. So with that self-assessment toolkit, which is called the Dementia 100, we started to be able to pull out some of the areas where we need to make the improvements. Can't give you a timescale at the moment. I'm sure you appreciate the ICB is going through a lot of change, but we are working across the ICB and with all our local partners to see how we can improve these local services. Really happy, obviously, to take any questions.
I'm wondering, Paul, have you got any comments? Thinking in with what you, not particularly.
I guess Nikki makes the point. It's not great, but it could be worse. You know, it's concerning. This is a growing need, and I think anything that we can do to improve people's experience at this difficult time is important. Nothing further to add, Chair. I'm sorry.
Councillor Stevenson, yes.
Yes, mine's a very simple question. Can we not open another memory clinic here in West Berkshire and then decrease the long queue and the referrals?
That would depend on resources, both in terms of staffing, whether we've got the staff to do that. So rather than sort of jump to a conclusion like that, what we need to do is understand what's happening in the memory clinics that we can improve on. So what are those bottlenecks, and then see how we can expand or improve on that capacity. So we're not there yet, Councillor Stevenson.
Okay, thank you.
Pleasure.
Councillor McCrow.
Well, it's not so much a question now, because I think it's partly been answered. It's more of an observation, because everything I read about dementia says that there's promises of lots of treatment options coming along, but most of them talk about slowing down the progress of the disease rather than a cure. So therefore, the earlier that we get a diagnosis, the better the outcome is likely to be. So I think we need to do everything we can to reduce these waiting times.
Yes, Councillor McCrow, you're spot on. The earlier we can identify people, and when we have those treatment options available, the better outcomes there are for patients. And there are new drugs that are coming through the National Institute for Clinical Excellence that have been approved. They're not into the NHS yet, but they are working their way through the system, which is a positive step.
I think I probably know the answer to this, but do you have to have a diagnosis of dementia to be referred to the memory clinic? Because if you're waiting all that time, you're waiting.
No, the GP will have an idea that you will suspect that there is an issue, which is why the referral is made. You don't have to have a diagnosis to be referred to it.
Okay, so having more resources. I mean, maybe, I don't know, is that something the Better Care Fund can be applied to, providing more memory clinics?
So worth me saying, so we agree the use of the fund for the year, and it goes through quite a significant piece of sign-off agreement processes. So I think we'd need to be careful about. I mean, I think we could talk about future years, but in year, I think we'd need to be careful.
I also think that it's an NHS responsibility to fund memory clinics, and the Better Care Fund is local authority and the NHS. So I think it might be some different support for people that would foot that bill. But I think we need to do that work around the memory clinics and see what we can do, and then come back to you.
Okay, well, that's important. Just that it's not a sort of particularly a partnership issue. I just want to ask about, obviously with dementia, you're talking about carers here, aren't you? Do care for carers, does that come into this? There is mention about the Better Care Fund being used in relation to voluntary sector support.
And that might be where it's appropriate that the Better Care, if there were resources within the Better Care Fund that could be freed up, or some more funding could be made available, that might be an appropriate use. At the moment, carers, we haven't got to that part of the work, but obviously appreciate the impact on carers in this area.
Yeah. I mean, we'll be looking at the carer strategy, I think, in future, and we have got someone in our community with long-term experience of caring who is I think she has asked a question recently at the Health and Wellbeing Board, or hopefully we'll be getting some input into this committee from her, because I think it's valuable to get the input from the people who are actually experiencing these things. One thing, probably, I don't know, there's nothing this committee can do about it, but I'm aware of respite care out there in the community, such as this, we've got a lovely new Camellia Club at Fairclose, but it's quite expensive. And, I know probably people are meant to pay for it through their attendance allowances or various things, but I don't know. I mean, I was a bit disappointed when I asked about this, that I was told about this, what I thought was quite a large cost. And then I was told, people can come for half days, but we haven't got any half day places, because obviously we will get more funds out of giving a full day place. So even that, because a half day would be a great help to some people, to carers, and probably a half day is all that some people can cope with. And yet they haven't got half day places because it doesn't cost too little. Yes, Paul.
I won't speak directly to the Camellia Club example, but I suppose what I will say is where an individual has been assessed as eligible under the Care Act, either the individual or their carer, then charges would relate, backtrack, where a person needs to access care and support, and it's eligible, and it's organised through us, they will pay what they are assessed as able to pay. So it depends on an individual's resources, income, etc. But please remember, I don't want people to see this and think, oh, what's the point of looking because it's too expensive. It will be expensive for those who can afford it, but yeah, people will only be charged if they're assessed as eligible.
That's useful to know, thank you. But they would need to be, so this is probably the GP that would refer in for an assessment, I'm assuming, or a other health professional? So,
and appreciate there's a lot of cross-cutting things here. So there are NHS services at the point of delivery, voluntary or private services where individuals might pay the full amount, where the local authority has assessed somebody as requiring particular support and there is a cost, the local authority will also assess them for their ability to pay. If they don't have if they don't have the resources to afford it, they will not be charged. So as I say, the multiple strand, complicated space, multiple strands here, but there are services that people would be eligible for.
It's really useful to know, because I think I'm coming across people in the community, and it's good for me to know that what happens. And am I right in thinking are carers also eligible for an assessment of their needs? Is that right?
Yeah, that's correct. Yeah. Again, there are very specific tests with it set out within the Care Act, but yes, carers can be assessed for their support needs as well.
Thank you very much. I think that's useful information, and thank you very much for your report. And again, this is something that we'll be keeping track of, and I'm sure we'll be seeing you again. So thank you very much for your report. Thank you.
Thank you, Chair.
Move on to item 13. We don't have a representative from Healthwatch here. I think we're all aware of the question marks over the future of Healthwatch, and we'd like to confirm that we value the work that they're doing. And I must say that when Councillor Stevenson and myself attended a recent joint health overview and scrutiny committee, and I think that was since the last meeting, all those present from the other health scrutiny committees in the region expressed concern over what's happening as regards Healthwatch. And if Healthwatch as an organisation ceases, then we do hope that it's replaced with something that will continue linking in with the community and giving us that valuable input about the public and their concerns, because I think it's something that we really, really need. We can't do that. Healthwatch has that link into the community, so we'd just like to express our support, and hopefully we will see them at the next meeting. Yes, Councillor McRae?
Yes, I mean, Healthwatch does various things. One of the things it has done in the past, which I don't think anybody else is able to do or does, is they've carried out surveys and assessments, to see what facilities, health facilities are required by people. And that's something we really do need in the future, I think.
Thank you very much. Yes, that's true. Councillor Foote.
Yeah, thanks, Chair. I mean, I would agree exactly with what Alan's just said, that the recording of data and information that Healthwatch gives us is very important. And also, I have to say that at the last meeting, which I'll be honest, I can't quite remember which meeting it was, but Healthwatch were there. And as you might know, we're in culture at West Berkshire. We're rolling out pop-up libraries. And we spoke earlier about the problems of dental practices out in the regions, you know, and the fact that some of our regions are quite isolated, and with pop-up libraries where you have members of the library team coming along maybe once a month, officers from West Berkshire can go out to those pop-up libraries, which usually tie in with a coffee morning or something like that at the local church hall or village hall. And Healthwatch were very interested in that because they can go out and do their health checks. You know, we mentioned also about dentists carrying out blood pressure checks, these sort of things. There's smoking cessation that, you know, we've mentioned, which seems to be one of the things that OHID it does tick their box, which is, you know, but what I'm trying to say is Healthwatch have a, you know, we've got the people already, so it would be great to just utilise that a little bit more, and I think that's the way we could probably do that. Thanks.
Yeah, I mean, I think they are struggling from the point of personnel, Healthwatch, but they are there to be used, and they have, I mean, they, as regards, you know, the surveys and the work that they've done, we're actually working with them with our women's health issue report that we're going to be bringing to a future committee. So that was an issue that they looked into, and we'll be very much looking at their data and working with them on that. So they've done some valuable, and they've done some very valuable work in the past. So I think we are very supportive of the work that they do. So yeah, so thank you for that. And yeah, great to hear the ways that pop-up libraries can be used. It's all linking in, isn't it? Okay, thank you, everybody. So item 14, the last item on the agenda is our work programme, which is on page 111. This is just highlighting the issues that are coming on the 10th of March. It's that one is probably sorted now. I don't know that we've got anything else coming to that, but we will be looking at other items for future committees, and if anybody in the public out there or any members have any items they think we should be scrutinising, we're always looking for you to bring them forward, and then we'll go through our template to see what the priority is. And but I think we have some other things in the offing, and we'll be looking into those. But we're just looking at our 10th of March programme at the moment. So any questions? Yes, Councillor McRae.
It's something for a future, possible future meeting. I say possible because it falls under the remit of children's and young people's scrutiny as well, and also I think resources in place. And that is Mosaic, the changeover to Mosaic, because it's
For what?
beg your pardon?
I didn't hear quite what you said.
It's the changeover to Mosaic and the migration to Mosaic, because it's very important. We've heard how we need Mosaic for some of the gaps in data. There's also the existing system is out of support, and I think it's costing us money to keep it running while we're doing the changeover. So I would think perhaps, I mean, they're talking about a target date of April. I think perhaps 6 months after, perhaps this time next year, perhaps we should look at how it's gone, how the migration has gone.
Thank you, Alan. Yes, Paul.
Thank you. Yeah, I would entirely agree that it is of relevance to 3 different boards. I think the conversations that I've had with colleagues has been that it's probably the resources scrutiny board that, if you like, owns it. It's a corporate asset. It's an IT system. They'd probably be most likely to, if you like, want to take the lead on that. But maybe it's a conversation between the respective chairs.
We certainly need to know more about that. So we'll be exploring how we inform ourselves. Yes, Councillor Kander?
So I was just going to say,
Sorry.
as long as one of the scrutiny committees looks at it, I think, but it'd be much overkill if 2 or all 3 looked at it. But certainly one needs to.
Sounds as though we all need to know about this. Yes, Councillor Kander?
Well, I think there's a task and finish group as well with regards to the Mosaic implementation, replacing care director, which I'm on, and I'm not sure when we're due to report on that. But maybe it could coincide with whatever report is finally issued as well, depending on the timing, if we're allowed to share that report. Yeah.
Yeah, it's certainly, well, it's something that we're having a conversation with Paul about. So we will be getting information back in some shape or form. But so there's a task group ongoing at the moment to do with Mosaic.
On the programme management of it, which so it may not be applicable, because I think some of the question really is, how's it being used and what will it be used for, and what data overlap there may or may not be, which might be part of the task and finish group, but certainly it's in terms of the implementation of it.
Thank you. So we'll be hearing more about that. Any other comments on the work programme? No. Okay, so I think that's all that it was on the agenda. So thank you very much for your attention. I'll mention again the aspect of members and whether you feel you want future training or more input on whatever you think might be relevant to getting the most out of this this committee. So please get back to Vicky and myself if you have any thoughts on that, and we'll try and set something up. Okay. Thank you very much for your input. Thank you for all your questions, and thank you to anybody out there if they're still there. Thank you.
Thanks. Bye.